All right, so we're speaking about understanding dementia and Alzheimer's and how family members can cope. Now, this is my wonderful grandmother. She is 84, I believe, this year. And having it such, my grandmother was diagnosed with dementia, I believe, 8 years ago. I was still in varsity at the time. So I have just noticed from the conversations that we're having over the phone, she's never been one to have many phone calls or phone call conversations, but from the conversation that we're having on the phone, there was a little bit of a lack of relatability. You know, when you're speaking to somebody over the phone as though you don't really know who they are, but you're just trying to be polite. Now, knowing my grandmother, she's the queen of politeness. So it seemed as though she was just being polite and not being very personal, if I could say that. We all have our personal nicknames at home, and you know, she just referred to you as my baby. You kind of know that okay, something's a little bit off, but we brushed it aside because we all assume that old people, when they age, develop some memory lapse. We think that it's a normal part of aging, not just the memory lapse, but they also start acting a little bit strange, and we kind of let it go. So we didn't send her through for any investigations initially because we kind of just thought, oh, well, it is what it is. But looking back retrospectively, knowing now what I do know, I realized actually that there are some of the things that she did alerted us early on to the fact that she did have Alzheimer's. And we just didn't really pick it up because we just thought it was a normal part of the aging process. And it was also just a normal part of, you know, growing, and her being surrounded by so many kids just made her a little bit confused and that kind of situation. But now we're able to see. So what I'm hoping is that in sharing this, we'll be able to pick up diagnoses a little bit better, quicker, so that we're not left kind of scrambling towards making sense of everything at the very end, close to the end of the diagnosis of dementia. So our outline for today, we're going to be speaking about what dementia is, the epidemiology, which just means kind of the spread of the disease, and the statistical view of the disease. Then we'll look at what the brain does, because I believe it's very important for us to know what the brain does in order for us to kind of think or to kind of realize what goes on in dementia. How can we spot it? And then the diagnosis of dementia, the treating dementia, and to go the nursing home route or not. And this is more in terms of what the family can do. I'm focusing mainly on the three most common types of dementia because there are many, but like Ms. Penkin actually noted before, that despite it being a diagnosis, or despite it being something that people are diagnosed with in their older age, you can have early onset dementia, which is quite devastating, but it's not the norm. Not just that, but you can have AIDS-related dementia, which can happen as a result of HIV, and in the later stages as the person develops AIDS, or so HIV-associated neurocognitive disease. You can have dementia associated with other things, and we'll go through that when we go through the diagnosis of dementia. So what is dementia? So it is, by definition, a number of closely related syndromes that are characterized by memory and intellectual deterioration, certain behavioral abnormalities, as well as changes in personality. So what we must note is that dementia is the umbrella term. So it's dementia in and of itself, just means a cluster of symptoms that we kind of put together. And then the names come in as the subtypes come in. So basically the actual definitive diagnoses comes in as part of the subtype. So for example, Alzheimer's dementia is a type, or Alzheimer's disease is a type of dementia. It has this cluster of symptoms where the intellect is actually impaired, the memory is impaired, behavior is abnormal, and there's changes in personality. Lewy body dementia is a type of dementia. HIV-associated neurocognitive disease is a type of dementia. So dementia is in actual fact the umbrella term for all of these small little diseases that give us the same cluster of syndromes or the same cluster of symptoms for us to call it dementia. Now, like I said, it mostly occurs in the elderly, although it is not alone in the elderly, because you can have early onset, although the most prevalent is that once you grow over the age of 60, we start going from mere 1%ers to up to 5 to 7%, and then it can even go higher after the age of 80. So if we look at the epidemiology, worldwide, about 35.6 million people suffer from dementia. This was in 2013. So the projection is that this has gone a lot higher. It's just that recent stats aren't readily always available, especially in our South African context. 5 to 7% of the elderly population is actually suffering from dementia. And in South Africa, it's about 250,000 people are estimated to be suffering with dementia. Now, I put that estimated in on purpose because a lot of the times, because we think that it is a normal part of aging, we don't necessarily actually send people through for diagnoses. So you'll find that a person's been sitting, when people reach me in the consultation room, they'll actually mention that this person's been like this for the past 3 years or for the past 4 years. But what they've noticed now is that she's not eating. So the thing that actually makes them bring the person in is a deterioration rather than them coming in from the very onset. And Alzheimer's disease accounts for about 75,000 of these people suffering from the cluster of dementia. So Alzheimer's is the most prevalent of them, but we'll discuss the others as we go along. Now, the duration of the illness is 10 to 15 years. So from diagnosis, one can continue 10 to 15 years. Some continue longer, some don't. And it also just depends on the management, the rate of infections that people get, and all of those things. Dementia in and of itself is progressive. So you go from one point of deterioration to the other, unfortunately. And that is the sad part of this disease, because you watch somebody go before they go. You lose your family members before you actually have lost them. So the death of the family member doesn't happen instantaneously as it happens in other instances, but they lose their personality, they lose what makes them that specific person way before they have actually gone down into the grave. So for example, my grandmother now, as I've told you the story, is bedridden and she's also mute. So she doesn't speak, all she does is eat, she has to be turned. So when we do go visit, it's not her, it's just almost a shadow of who she was. It's a body without, shall I say, the soul aspect, the thing that makes her her. And it's quite sad to see, and that's what makes the disease so dreadful, in the sense that the loss occurs way before, and the duration of illness is so long, with this progression happening gradually. So now looking at the functions of the brain, remember we said that dementia is a cluster where the intellect is disturbed. So what do we speak of, or what do we mean when we speak of intellect? So it is our innate cognitive ability, an aggregate or global capacity of an individual to act purposefully, think rationally, and deal effectively with the environment. Essentially, it is a sum total of our ability to make decisions rationally and effectively within the environment that we're in. So it is our capability to think and make decisions, our reasoning capability, and all of that in a rational manner within the environment that we're in. So let's move on to the next thing, behavior. So our intellect is our thoughts and our reasoning, and our behavior is more the response to the external and internal stimuli. So the response to our thoughts, underpinned by our moral beliefs. So essentially, it is how we then interact with our environment through actions, and not just the conceptualization, which is more the intellect side. And we learn appropriateness as we go. So if you can compare a 2-year-old to a 7-year-old, a 2-year-old, somebody will walk in and they'll say, "You smell bad." They haven't learned yet that this is inappropriate to say. They haven't learned to hold themselves in. They haven't learned to behave appropriately in certain social settings. A 2-year-old will take their food, smear it on top of the table, and it is not considered inappropriate because we know that they will yet learn this appropriateness as they grow. But if a 10-year-old were to do the same thing, then you'd know that there was something wrong, that they were being facetious, or that there's actually something wrong. A 2-year-old can wet themselves and we're not upset about it, but a 7-year-old, we would then be thinking there's something. So all of our behaviors are framed within the societal norms that we're in, but also we learn this appropriateness as we go. Very importantly, this appropriateness starts to deteriorate as somebody develops dementia, and certain types of dementia before others. So the things that we learn to control, to neaten up, to not say, to not do, to not swear, to all of these things that are appropriate behaviors, we eventually start losing them, or patients with dementia eventually start losing them as they go. And we'll discuss why later. So then that means that their behavior is inappropriate, that their behavior is intrusive. For example, if a child comes to you and says they want what you're eating, you don't think that that's a problem. But if an adult does that, then that intrusive behavior tells you that there is something wrong. Next is personality. So personality refers to the long-standing traits and patterns that propel individuals to consistently feel, think, and behave in specific ways. So it is, in essence, these enduring traits of who you are and how you interact with the environment. I'm, for example, a very talkative person. I've been speaking apparently since I was 9 months old. So my first instinct is to speak. My first desire is to speak, to socialize, etc. And that is how I interact with the environment around me and behave with the people around me. And it is an enduring pattern of behavior. So, for example, if on one day you find me not speaking, it doesn't necessarily mean that I'm not a talkative person. It just means that you have found me at a point where it is not in the pattern. I've had an off day, but there's an enduring pattern. So my grandmother, for example, is a quiet person. It is in the pattern of who she is for her not to be very talkative. However, it may be different. Although she's not talkative, she doesn't mind being around people. And what we started noticing was that despite her silence, she now no longer wanted to socialize or be amongst people. And now that means that the pattern of her personality, the pattern of her behaviors, the sum total of her behaviors as we looked at her had changed from how we had known her now post her diagnosis. Language. This is a combination of hearing, understanding, thinking, and muscle movement, specifically your mouth and tongue, to create meaningful language and interaction. So this is one of the most mind-boggling things, and it is great how God made this. There are different parts of our brain, and we'll go through this later as we go through brain mapping. And I think my computer is now stunting. Okay. Just forgive me there for a second. I don't know what is going on.
Sometimes just click on the slide, Dr. Palesa. If you click on the slide and then you just carry on.
Okay, it seems to have fixed itself. No, and now starting again. I think it just doesn't want the video and the presentation going on at the same time. So I'm going to switch off the video and just continue with the presentation for some strange reason or the other. So let's see, now it is no longer moving. So when we speak about the memory, I hadn't reached memory, I realized, but I think my computer has just started stunting a bit. But when we speak about language, which was where I was, the language capability is our ability to share, to understand, to think of and conceptualize language, basically. So when somebody says something to you, we combine everything that we hear, everything that we know of words, everything that we know of the thing that they're saying, everything that we know of the things that we are hearing, and even filter out some sounds in order for us to then create language and to understand language. It is a wonderful thing, and different parts of our brain are actually responsible for the different aspects of language, but they all come together in order to create a meaningful interaction. So we'll go through this later when we look at brain mapping, but there are different facets and different aspects of our brains that are in charge of these different parts, essentially, of our language. And then memory. So Memory is mostly within the hippocampal formation, and which is especially important for episodic memory. So now, in terms of our memory, we have different kinds of memory. We have our semantic memory, our episodic memory, our procedural memory, our working memory. So the first three are long-term, and the last one is actually short-term. So in terms of our semantic memory, it's our knowledge of words and their meaning and objects. A lot of people refer to it as the what of memory. So when you pick up a pen, you know that this is a pen. When you pick up a water bottle, you know that this is a water bottle. If somebody asks you the definition of the word integrity, you know the definition of the word integrity. Our episodic memory, however, is more our historical memory. This is actually typically what we think of when we speak of memory. The idea of personal events, stories, where you're able to combine the what and the where of things, as well as other things, the smells, the sounds, all of these things into a picture and a re-experiencing of the events that we've actually experienced. Memory is also one of those wonderful things that God has created, in the sense that we're able to relive old moments while not really reliving them. So this is mostly within our episodic memory. Our procedural memory is what we mostly refer to as our muscle memory, our ability to perform tasks, or skills. So this is how you learned to tie your shoes. Knowing to tie your shoes is actually the procedural memory. Knowing how to ride a bike, knowing how to play tennis, all of these are procedural memories. And these now interact in a sense, because you may have a story related to how you learned how to tie your shoes. So it may not just be the procedural memory in and of itself. The procedural memory may be there, but there may be an episodic memory that is attached to it. And you also know the word for shoelaces, which is where your semantic memory comes in. So all of these interplay and interact with each other. And our working memory is then essentially our short-term memory. It's a limited capacity for short-term use. So this is, for example, if somebody gives you a number and they say, please enter this number quickly into the phone, it's 45815. That is short, quick. I don't need to really remember this for long-term use. I just need to use it for something. 4 cups of baking powder, 4 cups of flour in a cake. I don't need to remember specifically the specific recipe, but I will remember the short aspects of it in order to help me fulfill the task. And what we often see is that in dementias, the working memory is the first to go. This is also because our long-term memory is, because like I said, all of these memories interact, our long-term memory is stored in these long fibers and multiple neuronal connections. So for it to actually disappear is quite tricky. It takes quite a long time for the long-term memory to disappear. But our short-term memory hasn't really found its way into making long-term connections, if I can say. And therefore, because of that thing, our working memory, our short-term memory is the first to go. So you may find that somebody is wondering where they left the keys several times a day, where they have put the remote several times a day. This is all the working or short-term memory that is easily affected first in the dementia diseases. All right, so the brain mapping that I was mentioning earlier, if you look, all of the different colors represent different parts of the brain that are responsible for different things. Now, this is a very simplified way of looking at it, although even our concept of brain mapping is somewhat simplified, although this is an oversimplification, but it does help to understand what goes where. So if we start at the very bottom here, that blue core, which is the brain stem, and this is responsible for basically our body basics, our heart rate, breathing, alertness, sleeping. It's in essence the clock of our brain, the thing that keeps our body working, moving, all of those things, right? And at the back of it there, you'll see the small brain, which is actually its translation, the cerebellum. And this is responsible for coordinating our movements and skill memory. So dancers, for example, have been shown to have quite developed cerebellum, and this is because they fine-tune their movements quite a lot, more than most of us. The green over there is the temporal lobe, which is responsible within our cingulate gyrus and other parts or the hippocampal formation for memory. And then the other parts of the temporal lobe are responsible for language comprehension, and we'll speak about that a little bit, for our recognition of smell as well, identification and naming of specific objects, and also it has some part in hearing. Then if you look at the purple over there, the parietal lobe is responsible for sensory connections or for sensory pickup, for information and spatial awareness. Like I said, much of a simplification, but it does help us somewhat understand. And then these two over here, the orange and the red, are our motor and sensory cortex. So our sensory one is to pick up sensation, and our motor is to initiate movement, basically, initiate purposeful movement. In the front over here, you have the frontal lobe, right? Which is responsible for emotion, for decision making, for stopping of perseveration. So this is repetitive tasks, doing things repetitively. We kind of know to stop at some point, and our frontal lobe also helps with that. It helps with us not mimicking things. So for example, if you look at a child, when you pick up a child and you smile, they will mimic that. Their frontal lobe is not 100% fully formed in order to kind of filter that out. So our frontal lobe can filter out these things, and our prefrontal cortex is responsible for our short-term memory, as well as our ability to pay attention, as well as our ability to kind of think and make rational decisions. This is also thought to be where we house our personality. And we'll see that as we go along. I also have some pictures of scans that will show where things go wrong, essentially. So if we start off with Alzheimer's dementia, which is the most common of the dementia, essentially what it is that, or what happens is that there is a loss of the neurons in the cortical area. So neurons are the brain cells, and the cortical area is essentially the top part of the brain, and some subcortical regions, which is now deeper on in the brain, which results in generally a loss of brain volume. So when you look at the brain of this person in a scan, they've lost some of their brain volume. The cingulate gyrus, or the hippocampal formation, is the part that is also very affected within this type of dementia. They also have these amyloid plaques and neurofibrillary tangles that are present, which are thought to be what kind of starts off this process of the loss of neurons, and also propagates it in the sense that the lost neurons are then replaced by these tangles. The area at the back of the brainstem that I showed you, there's a part of the brainstem that's referred to as the pons. And this pons degeneration happens at this area called the locus coeruleus, which is where our brain kind of has our sleep cycles stored. And then later on, there is seizure activity that is involved in Alzheimer's dementia, and I'll explain why shortly. So the clinical presentation typically is people from the ages of 60 and above, and it is associated with, there is some association with a history of depression, some genetic predisposition, and a history with metabolic disorder. Now, these are just associations, but association does not mean causality. So what I mean by that is merely having the association does not necessarily mean that that is what has caused it. You can look back and think, hey, maybe that's the real thing, but it's just more the association. So even our understanding of the genetic predisposition is not really wholly refined, because we can't say it is in this specific gene, etc. But we are starting to see that there may be some kind of a pattern of genetic predisposition. And with the metabolic disorder is a combination of your high blood pressure, obesity, diabetes, high cholesterol. And we're starting to see that this metabolic disorder does predispose people to developing the dementia. And the other reason is that Alzheimer's often also presents as part of a mixed dementia, which is more than one dementia occurring at the same time. And the kind of dementia that is more likely to occur with a metabolic disorder is a vascular dementia. So we're not entirely sure if it's the vascular dementia aspect alone, or if the Alzheimer's dementia alone also kind of propagates that. So with the clinical presentation, the memory impairment happens very early on. If I remember with my grandmother, there were times where she'd even now start to say, she forgets so much, but all of us thought it was normal. But once again, it is not a normal part of aging. And it's usually the episodic memory that goes first. So this is now the relation of stories and events that happen. And she was struggling a lot with that. The short-term memory is affected at the very first, so she'd struggle with remembering where the keys were, etc. But then eventually the declarative memory or the episodic memory happens, where now even events You may have gone with her somewhere and she has no recollection of that having happened. And then later on, the last of all to go is the procedural memory. So knowing how to brush your teeth, knowing how to comb your hair, that is the last of all of them to go. So they then also subsequently develop executive function impairment. So they struggle to actually execute tasks that are given to them, especially tasks that have more than one step. So for example, please put on your shoes, tie your shoes, let's go outside so that we can sweep the yard, and then do the garden. Those things require several tasks. There are several minute tasks, and they struggle with those tasks to be executed. The other thing is lack of insight. So they do not actually recognize that there is something going on. They may, especially early on, recognize the fact that the memory is impaired, but as the disease goes along, they do not actually recognize that there is now significant impairment. They do not recognize that they've lost the ability to brush their teeth. They do not recognize that that is a problem. So that is what we mean by lack of insight. And then they develop this visual spatial impairment early. And I'll show you how we test that. But this is an understanding of the sight or the vision and how we interact with the space surrounding that. And then language is later affected much later in the disease. Then in terms of the behavior, there's usually a withdrawal, apathy and social disengagement, and later on they can develop some wandering, so just aimlessly walking around, and then some psychotic features. And what we mean by the psychotic features is they can have hallucinations, some delusions, and inappropriate behavior that then develops. Then the last thing is apraxia. So apraxia refers to an inability to do learned tasks, normal learned tasks, and this is things like tying your shoes, brushing your teeth, brushing your hair, writing in some cases. So they do develop this lack of, or this inability to do learned tasks. And then the last thing is that they also can develop sleep disturbances or fragmented sleep. And this was the first thing that I had noticed about my grandmother, was the fact that although she used to sleep, she had a great biological clock, but there was a day where she woke me up for school at 3 a.m. and I didn't understand why I felt so tired. But then I subsequently, now looking back, realized that she had this fragmented sleep and she was unaware that her normal sleep cycle was now being disrupted. So she'd sleep quickly, wake up quickly, and she'd think she had had a full cycle of sleep or full night's rest. So if you look at the brain of a person with Alzheimer's, this is essentially a drawing of what we find at autopsy. If you look at the cortex, which is the outside of the brain, the more pinkish part, if you look at the volume of the cortex versus the volume of the cortex on the other side, you can see that there's significant loss and there's significant shrinkage. And what is very nice to note in this picture is that the hippocampus is basically vacant. The hippocampal formation is now basically gone, which is where our memories, especially our episodic memory, is stored. And this is why I mentioned that idea of episodic memory and the hippocampus formation early on. And this is the first to go within the dementia. So they have a general loss of this cortical brain matter as well as this hippocampal brain matter. Once again, just another picture showing the loss of brain volume and the loss of cortical brain volume, as well as the loss of hippocampal brain volume within this kind of dementia. Next in line, another quite common one. This is the second most common one after Alzheimer's dementia, which is a vascular dementia. And it is caused by impaired flow to the brain due to cerebrovascular disease. So what we know as strokes essentially causes reduced flow to the brain, blood flow to the brain, and this causes the cells to die. And these brain cells, as they die, then they lose their ability to function, and then you have essentially some loss. So this is usually after a stroke, which is then followed by dementia, or it can be because of brain image that you see, a CT scan or MRI that you see in a patient who has dementia, but previously was clinically without a stroke. So the family will tell you that she's never had a stroke before. When you look at their brain, you'll see that they had these multiple small strokes that were missed early on. So because they didn't cause significant damage, they didn't cause their arm, leg, face to grow lame, we didn't note it as a stroke, and people didn't then present the patient to us. But in actual fact, it was a stroke, but it was missed but it didn't cause significant motor loss, if I can say it that way. It's usually part of what we call mixed dementia. So more than one kind of dementia with another. It's usually associated with either Alzheimer's dementia or with Lewy body dementia or with one of the other kinds of dementia. Once again, the risk factors are metabolic disease and smoking. And this specifically in this dementia, there is a very strong correlation because of the fact that, remember, it has to do with cerebrovascular disease. So your blood vessels being unhealthy because of high blood pressure, diabetes, high cholesterol, high BMI, and smoking, all of that is putting one at risk for developing the vascular dementia. Now, interestingly, in this kind of dementia, the episodic memory is spared. So the person is still able to tell you events that happened long ago, but the other cognitive domains are affected. And this is now your visual spatial intelligence, your executive function, your judgment, all of the other parts are actually impaired, but their episodic memory is great. And the reason why we miss a lot of these vascular dementias is because people don't think it's dementia because they still remember, the patient still remembers things. And in most cases, then it just kind of seems like the person's acting a little bit strange, or you notice that when Ma is cleaning the kitchen, she's not fully cleaning it as she used to before, but you're not fully noticing why. So personality and mood changes are possible, and they are associated with gait slowing. Now, because of other comorbidities, like especially in these patients, because they have the high body mass index, the gait slowing is often missed because you just think it's a heavy set person who probably has osteoarthritis. That's why they're moving a little bit slower, but in actual fact, it may be a presentation of this vascular dementia. So this is a CT scan of a patient. The black parts on the outside are the normal CSF around the fluid around the brain. Now, within the middle of the brain is where our CSF is stored normally. But if you'll see, and I'll show you an MRI picture after this, if you look at the back, there's an area further down, just after those ventricles where the CSF is stored, where around the ventricles, there's this darkening. And that is showing some previous injury that has happened. I'll show to you, this is now the image I'm going to show now is an MRI, which makes those areas light up, and that will be easier to see. So the black is where the CSF is, where the cerebrospinal fluid is, the fluid around our brain. But the white areas are these small, and you can see it almost looks sometimes like little spots, small mist strokes essentially that happened and that have now caused this vascular dementia. All right, the third most common is a frontotemporal dementia. And this, within this dementia, the memory loss is not too prominent, but there is a degeneration of the frontal lobes and the temporal lobes, which results now in early personality changes. Remember when we spoke about our frontal lobe, we said that our frontal lobe is responsible for housing our decision-making centers and our personality. And when in this kind of dementia, the frontal lobe actually degenerates a lot quicker. So they develop some personality changes as well as apathy and disinhibition. And this disinhibition is what I spoke about, of almost the childlike behavior of saying things that they shouldn't say, that are inappropriate to say, doing things in an inappropriate setting. So you may find that the person relieving themselves in front of people, this is a disinhibition, or asking for money from people that they don't know. This is a disinhibition. You have a perseveration of motor tasks or cognitive tasks. So they may repeat the same thing over and over and over again, or they may it may also make them look somewhat OCD. They may keep wiping the table over and over and over and over and over again, because that part of the brain that kind of tells us that you have completed the task is not functioning well. And this also comes in with the ritualistic repetitive behavior, which is the same thing or similar thing, where they sweep countless times. And you may think, okay, maybe she's just really clean, but in actual fact, it's this repetitive ritualistic behavior. And like I mentioned, the disinhibition, which here is quite disabling with that apathy. I mentioned them separately because I did want to speak about them somewhat separately. The disinhibition I've touched on quite a bit, but the apathy can be mistaken as somebody just seeking solitude, but in actual fact goes on beyond that. The person now no longer wants to interact even with people that they enjoyed interacting with before, with behaviors or things that they interacted with before. They may even, if it was somebody who liked going to church, may feel as though they don't want to go to church. And this apathy is often actually mistaken for depression, which can happen concomitantly, but a lot of the times it's missed because you just think that the person's feeling a lot low. And remember, because our dementias occur in elderly people, sometimes we do think that this is because of loss that they've experienced. Maybe they're missing this person that they've lost specifically, but actually that apathy can be coming from another place. The other thing that may happen is that they may eat beyond satiety. So you'll find that the person continues eating and eating and eating whatever you put in front of them. They may just continue eating, and that's because the part of the brain that tells you to stop eating, which is our frontal lobe, which tells you it is now inappropriate to continue eating, just continues, and they just keep on eating. They may develop some Parkinsonisms. So this is actions that are similar to those of Parkinson's. So the shaking, the shuffling gait, the lip smacking, the bead rolling, the slow, very slow movements. Then they also have a diminished capacity for abstract thinking as well as attention that occurs with the progression. So abstract thinking is thinking that isn't concrete. So concrete thinking is very one-dimensional, if I can say, but abstract thinking requires you to think of relatability of things and put them together. So for example, what we ask in the test to test the abstract thinking is we'll ask, how are a banana and an orange related? And one would say, because it's fruit. But in these patients, you'll find they'll give you answers like, because bananas, you can use them and you can put them in the bin. But the ability to correlate things that aren't concrete is diminished. And this is kind of what we see with kids. So like I said, that this frontal lobe where we house our personality and our appropriateness kind of goes away. And then they subsequently develop non-fluent aphasias. So an aphasia is a speech or language inability. So a non-fluent aphasia means that they have reduced ability to find words, to speak words, but they may still properly understand language. So if you tell them to lift up their hands, they'll understand completely. But when they are trying to express themselves, they have a very strong difficulty kind of expressing themselves and finding the words to express themselves. And this non-fluent aphasia eventually goes on into mutism, where the person stops speaking completely. So this is an MRI scan, and it shows the parts of, thankfully here it's nicely highlighted, it shows the parts of the brain that are now being chewed away. Remember, the black is where brain fluid is, but our brain fluid isn't meant to be seen to that extent. And here we're seeing there's a large amount of brain fluid surrounding the temporal lobe, which is showing that there has been loss of this temporal lobe. Even here in picture B, where the frontal cortex, if you look at it, comparatively, it's mainly just streaks of brain that are just left behind, and it's showing a significant shrinkage essentially of that part. So they have significant frontal and temporal lobe shrinkage in this one. So how do we diagnose dementias? Remember, I had mentioned it's very important to actually seek medical attention. And this is mainly because you may have reversible causes that kind of present themselves as dementia. So, for example, thyroid disease can present itself very similar to dementia. And you may think, my family member's dementia, fine, let me just keep her in the house, let me take her to a nursing home. But if you do not exclude these reversible causes of dementia, then you would have done them a disservice, because now it's not actually a real loss of a brain volume, it's actually just a reversible cause. Other reversible causes include syphilis, include some endocrine abnormalities, include some electrolyte abnormalities, but that's more a delirium. But if you're untrained, essentially, you'll basically think of them as the same thing. And you may also have some tumors that will look like dementia. So that's what I refer to as space occupying lesions. Tumors where they are in the areas that would cause the significant loss of function like a dementia, but in actual fact, it's not a dementia. So all of these reversible causes must be excluded. The other deficiencies, including B12 and folate deficiencies, vitamin B deficiencies, all of these things must be thoroughly and completely worked up in order for us to say that this is a proper dementia. So you must have blood taken as well to exclude these reversible causes. The other thing that you need is brain imaging in order to also help categorize which kind of dementia it is, as well as to exclude space occupying lesions. So your masses that would basically mimic your dementia. A lot of the times we do end up getting psychiatric evaluation because depression itself is a reversible cause of dementia and may mimic dementia. Remember, we spoke about the apathy that kind of presents itself with these patients. So you may have a patient that is very apathetic, now no longer speaking much, has some memory lapse, and you'll think that this is dementia when in actual fact it is actually depression. And this happened, I mean, recently with me, with a patient where I thought it was dementia, but one of my seniors said, try this patient on antidepressants. And after we did, within a month's time, the wife reported that he's interacting well, his memories improved, he was now oriented to all spheres, so he had made a remarkable recovery. So it would have been a great disservice for us to merely say that he's got dementia, which carries a relatively sad prognosis in the sense that there is no direct intervention. Whereas we could have actually treated and given this person a significant change in their lives. So the other thing that we do is a mini mental state exam, or MoCA, which is a Montreal cognitive assessment. And I'm going to go into a slide that shows this Montreal cognitive assessment, this MoCA that we do. So if you look at the top right corner, we ask them to draw a clock. And this shows their ability to, their visual spatial ability. So when we draw, if you were to draw a clock now, the first thing that you do is you draw the circle, fill in for the most part 12, 3, 6, 9, and then fill in the other numbers in between. And this is showing that you are planning out your visual spatial field in order to fill this in. Then you'd fill in your, it says there that you must put the clock at 10 past 11. So then you would know that the long hand goes at this point and the short hand goes at some other point. But once you develop a dementia, a person may draw a very small circle and draw all the numbers outside, or they may draw a huge circle and put the numbers only on one side, or not even fill in the numbers. It may just be not even a full-on circle or square or whatever. It may just be an indistinct shape, which shows significant impairment of their visual spatial intelligence. The other thing is to copy the cube above, which also just shows the visual spatial planning and executive planning. And then the other thing would be to correlate 1 and the letter A, 2 and the letter B, 3 and the letter C, to kind of think of these patterns. And this also shows your executive and visual spatial intelligence. Then next is naming, which kind of tests our language ability, because in order to remember, I said there are parts of the brain that are responsible for specific naming of things. So it's our language ability, but also part of our memory, because remember we spoke about the kind of memory where the semantic memory, where you learn the words of things. So patients will often look at this, sometimes, they'll look at it and say, it looks like a dog, or they'll say it's that one that roars. But there's an inability to actually name the object or the animal. Then next is to check their memory. So you'd give them 5 words, and then you'd ask the words later on in 10 minutes, and they must recall all of these things. Then you check their attention, and they basically have to repeat things in order or backwards. You read a list of letters, and they must clap every time they hear the letter A, which shows that they're paying actual attention, or they must subtract 7 from the number 100 and go down, basically 100 minus 7, 93 minus 7. And now what you must notice is that we also do account for highest level of education. So if somebody is uneducated, we don't necessarily penalize them because of that. There are points that are added, but one of the main issues with this is that you do need to do it in the language of the person, which can sometimes prove difficult. Then the other thing is testing their language, so their ability to repeat, which sometimes becomes impaired depending on which part of the brain is impaired, as well as their fluency, and then their ability to name something starting, for example, with the letter F. And they may find it very difficult to find those words. Then the thing that I was speaking about earlier was the abstraction, the ability to think in non-concrete ways. So how are a train and a bicycle related? They may tell you that a train and a bicycle are related because they've been on both of them, but that's not actually the relation. The relation is, for example, accept that they're modes of transport or that they both have wheels, but they sometimes may have, poor abstraction. And then the recall, which is basically recalling those 5 objects before and seeing if they are able to remember them. Then the last thing is orientation. So this is very important because in an acute setting, so basically under 6 weeks, 6 months, somebody can have what we call delirium, which is basically an acute confusional state, which is a short-term state. And that's usually because of drugs or metabolic disturbances or electrolyte disturbances or an infection, and they may become disoriented, which must be excluded in order to make the diagnosis of dementia. And in long-term demented patients, they actually lose their ability to think of where they are in space and time. So like children don't know what the date of today is, where they are, what city they are in, people with dementia also eventually lose this ability, so they can become disoriented. So they don't know the date, month, year, day, place. If you ask them who the president is, they have no knowledge of who that is. They're basically just existing in the current. So how do we then treat these unfortunate diseases? So there is no definitive treatment for non-reversible cause of dementia. Now, remember, I did mention that it is very important to exclude reversible causes of dementia. But if it is an irreversible cause, there is no actual definitive treatment. There's no pill that you can give to make the dementia go away. There are just supportive things that we can do. We in the hospital settings, in patients who have now developed psychotic symptoms or behavioral problems, we can use antipsychotics. Sometimes it works. We usually give a trial and we ask the family to come back and report to us how it went. Sometimes it makes them worse. So it just depends on this person and their individuality and how they will then respond to this medication. And then the most important thing is the non-medical supportive treatments. And this is where the family becomes very important. We come in for 20-30 minutes, do the assessment, do the scan, tell you what the results are, but we are not actually the most important part of the treatment or the most important part of the management. The other parts of the support system of this person are the most important parts. So how can we be of support to people that are diagnosed with dementia? Most importantly, accepting the diagnosis as the family. You kind of save the person a lot of strain and up and down in terms of medical facilities, and a lot of friction within the family if the diagnosis is accepted. Now, not to say that it's wrong to seek a second opinion, but if you've gone to 2 doctors and they've both said, listen, I've looked at this, I've looked at the scan, I've looked at all of this, and this looks like this person has dementia. A lot of families struggle to accept this diagnosis and then take the person from pillar to post, trying to find alternative remedies, trying to find alternative solutions, trying to find alternative diagnoses that could fit the picture, that are tested and excluded. So the acceptance of the diagnosis is so important from the part of the family, especially if the diagnosis is made early on, while the person still has some of their brain function left, because then you can start to help them navigate the space. You can start to help them navigate the idea that this is going to get progressively worse, but we are here. Start reading up, start seeing how else a person can be there. And when you do not accept the diagnosis, it confounds, because now you're dealing with your own emotion, own stress, own whatever, on top of the patient. So that acceptance is very, very important. Because then you will not be able to, I guess, make appropriate plans if you do not accept that diagnosis. So importantly, to keep the patient in familiar surroundings. So this is what I mean about the acceptance of the diagnosis. Sometimes because the person has lived, for example, my grandmother had lived in my hometown for years, and to take her out of that situation, she attempts to live with my uncle. It wasn't even to live with, it was just for a visit. That experience was very disorientating to her because she'd wake up and she doesn't know where she is. She can't think of where she is. She has no memory, concrete memory of this place. And it made it very difficult. And that kind of really upsets them because at this time, even at a point of early diagnosis of dementia, it makes them feel a lot worse. So because the familiar surroundings are also helpful because there are familiar faces, familiar people, neighbors who also are invested in the care of this person. And I'll bring that up later. Maybe we can speak about it now. The familiar surroundings, like I said, the neighbors also play a part. I mean, my grandmother would often wander. We'd lose sight of her for 2 minutes and she'd be at the gate. And we wouldn't be sure which side she went. And we usually have people that are sitting, close to the house, and they'd tell us, no, she went into this specific person's house. So they were able to keep track of her at times when we would lose track of her. But these familiar surroundings really do help. I mean, she even knew certain neighbors' places, merely from just having lived there for very long, and that her memory of that had not been affected. So to put somebody out of the familiar surrounding kind of does disorientate them quite a bit, especially early on. Now, the other thing is the reassurance without being condescending. So a lot of these patients, especially early on in the diagnosis, still have somewhat of their brain function. So to not speak down to them, to realize that this person, I mean, in most of our setting, it will be our grandmother or our parent. This person is still the parent that I know, and to give them reassurance of that love and the reassurance of their space as the parent, without necessarily being condescending, without using a condescending tone, without speaking down to them or making them feel as though they are a child. That reassurance is very important because, like I said, a lot of the times patients can develop concomitant depression, and sometimes what ends up depressing them is the idea of the fact that they're losing their cognitive ability. Daily orientation. So when the person wakes up in the morning, you can, greet them well, say, hi, today's Wednesday, it's a wonderful Wednesday morning. In Johannesburg, to just kind of remind them, give them the familiarity of where they are, especially in hospitals where patients are. They actually do a formal orientation where they tell you where they are, what day it is, etc., so that you can also keep track of the fact if they are becoming disorientated to their time, place, and person. And you can do this in subtle ways without necessarily being completely upfront about it and condescending about it. To keep objects in familiar places. Try not to rearrange the house very often, because if it's just orientating for us, now imagine somebody who is losing essentially parts of their brain function. Ensure the patient isn't left alone for significant periods of time, especially if they lack insight. And because of some of the time that they may have this lack of insight or lack of ability to realize that there's something wrong. Somebody may take the keys and go and then only realize once they lost that they do not know where home is. So ensure that there is adequate monitoring, adequate supervision, and that they aren't left alone for prolonged periods of time. This is where accidents happen. This is where someone may burn the house down because they didn't recognize that they were doing something that was dangerous. Adequate nutrition. And this is because the nutritional aspect is important, because nutritional deficiencies then can also worsen the outcome of the dementia, and they can worsen the general outlook of the patient, of the person. So you must ensure that they're getting regular meals, good meals, healthy meals, although sometimes they may fight you about those meals, but just also reinforcing the eating in a way that is patient, that is kind, that is also not entirely condescending, but giving the person somewhat of an essence of control over what they're eating and a choice in terms of what they're eating, but just making sure that the nutrition is preserved. Music is quite interesting. Our music is actually stored, or our recognition, our memory of music is stored in more than one aspect of our brain. So you may find that somebody with dementia, although they may be losing their memories, may remember songs. They may not remember specifically how they know the song, or sometimes it may actually jerk a memory for them. So keeping music around, I mean, it also elevates the heart and elevates the mood. So cheerful, tasteful music that the person enjoyed, has been shown to be somewhat helpful. And it does also help with the interaction when words kind of fail between the people. The music kind of keeps the bond going. This being surrounded by children. Now, this is something for me that's very interesting. Intergenerational care is now becoming the thing in certain countries where they are allowing children in daycares or creche to visit old age homes. And they are showing that both parties basically gain quite a bit. So the first thing that they've noticed with the elderly was that it preserves their utility. There are things that kids know or kids don't know that the elderly may know. And now with you, who is in the prime of your life, you may not necessarily recognize that the person still knows this thing, but the child will ask, grandpa how to open a tin, and grandpa now feels that they still have a sense of their individuality in adulthood, and they still know how to dust a shelf and show them how to dust a shelf. So it preserves their utility, and because of that, kind of boosts their self-esteem in the sense that they do not feel that they're a complete burden. Then the other thing is that they learn together new things and old things. So a child will come and say, Opa, I learned how to tie my shoes. And Opa has forgotten how to tie his shoes. And now he says, show me. And they learn together without the judgment that would come from an adult, without the irritation that would come from an adult. And just also the idea of play together, a childlike attitude that lacks judgment, that doesn't realize that Opa's brain is not what it was before, but rather sees Opa as a fun guy who is willing to play with whatever toys I'm playing with, but does not realize that actually, even in playing with those blocks or playing with all of those things, they're improving both of their visual spatial intelligence. And now the question of the nursing home versus the non-nursing home. So this is a very difficult decision. And you can see before that I spoke about familiar surroundings, but I also spoke about not letting the person be alone for prolonged periods of time, which is difficult because we all work, we're bogged down by our own family. So how do we then make this decision? And it's a difficult decision, and individual circumstances must be taken into account. It would be unfair to say that the most familiar setting for a person is their home, and therefore don't take them to a nursing home, because then you compromise their care because you're not there, and you're also not there to feed, to watch. It requires quite a bit of patience to manage patients like this. So one must, or the family must sit together and make this decision together, taking into account the family's finances, the family's circumstances, the surrounding areas. I mean, stay in a very dangerous area. It may be quite dangerous for a person to stay with Alzheimer's, to stay in that area, because the moment they leave, they may be abducted, they may be killed, so all of these things must be taken into account, and there is no right or wrong decision. But the most important thing is that there must be constant, meaningful interaction, and I'll get to that shortly. Carer fatigue is quite a thing, because it requires, like I said, a lot of patience and a lot of understanding to deal with people with dementia. And there is quite a significant amount of pushback. So you must be basically quite well equipped, patient. There must be a lot of, shall I say, taking turns in terms of taking care of the person, not necessarily moving them around, but ensuring that there's somebody to relieve you at night so that you can sleep. Otherwise, the care fatigue can sit in, and that can lead to guilt, because you feel as though, how can I be upset about taking care of my grandmother? How can I be upset taking care of my grandfather or my father? But in actual fact, it is the actual strain of doing so. And that guilt can often be disabling, which would then result in the other person developing depression. So you have to watch out for the care fatigue, but there's also the guilt in the nurse's home of how did I allow my mother to end up in a nursing home? Does that mean I don't love her, etc., etc.? So the playing of these, you will not feel less guilty with the person at home versus with the person at a nursing home, because the care fatigue will result in guilt. The nursing home will result in guilt. There will be guilt in all spheres, and that's why the idea of having a strong support system, even for the carer, is so important, to relieve the care fatigue, to relieve the person of some of the duties at some point, so that the person also has a life outside of this person, and then don't develop complicated grief should they lose the person. So it is a difficult decision, but it requires looking at your individual circumstances and making that choice. The most important thing, whether one picks home care versus nursing home, is that there must be constant, meaningful interaction. It is easy to lock somebody up in a room at home and say that I'm taking care of my mother at home, but all you actually do is bath and feed them without actually having meaningful interactions with them. It's still a person, they're still a person behind what the dementia has done to them. And you must try to keep that meaningful interaction. Try to keep that person feeling like a person. And it's very easy on the other side to take a person to a nursing home and never see them again until the day of their funeral, which is what we see quite a lot in the hospital, where we will struggle to get hold of family members once the person is admitted. But so the most important thing is that there must be this interaction where I visit constantly, I'm there constantly, be it on a Sabbath, where we'll ensure that we have Sabbath lunch at the nursing home, or during the week, but there must be some constant, meaningful interaction with the people that the person knows already, so that they are also not essentially abducted from their normal community, even at home versus at the nursing home. So the middle ground for this would be home-based carers, where people are hiring live-in nannies or nurses to come and help out in the homes. This is quite an expensive option, but it is becoming a more preferable option with quite a lot of people. But once again, your circumstances may not permit. You may not have the space, you may not have the funds, and this is where the most important thing is that this person must still be treated with the respect, dignity, and love of them being your family member, and thus must not be alienated from the family, whether at home or in a nursing home. I'm going to end it off with a quotation, and this is in Ministry of Healing, page 203 and 204. It says, "So far as possible, let those whose whitening heads and failing steps show that they are drawing near to the grave remain among friends and familiar associations. Whenever they are able to do so, it should be the privilege of the members of every family to minister to their own kindred. When this cannot be, the work belongs to the church, and it should be accepted both as a privilege and as a duty. All who possess Christ's spirits will have a tender regard for the feeble and for the aged." So the family members play a very important role, but we as a church community also play an important role. So should we have a church member who is afflicted by dementia, it is a part of our duty and privilege, she says, to ensure that we are constantly interacting with this person and ensuring the care of this person. Should we have a family member that maybe we aren't able to look after personally, we should have an active role in constantly visiting and interacting with them. And even if they are at home, not to think of them as mere pieces of the furniture, but to have a meaningful interaction with them so that they too can continue to have the dignity of a human being, of being a human being, and the love that comes with being in a family. So we're going to end it there from me, and then we'll be free to take questions, etc.
Thank you, Dr. Palesa. If you can just, I'm going to stop the screen sharing. Dr. Palesa, do you mind just explaining the shadowing, why people do that? Because I know there are people who on the platform who are experiencing it, and why shadowing the person closest to you is so hectic for people with dementia.
Okay. I don't know if I'm unmuted. Am I still unmuted? My screen is just doing
you can speak. You can speak. It's
okay, sure. So a lot of the times, the idea of the safety and the protection that comes with a familiar face, a familiar person, as much as children, how mothers constantly complain that they can't even go to the bathroom by themselves. It's a primitive display of safety, if I can say, where they feel that they must be closer to this person in order to maintain their safety, and then thus end up shadowing them. So it's a compliment in a sense, because this is where they are feeling that there's a sense of safety and that this person kind of cares for me in this specific space, and therefore I'm safe if I follow them around. And remember, because they've lost that cortical ability to show them that this is an inappropriate behavior, it continues to persevere.
Okay, I thank you so much. Also, they say they will do it like on the side, they'll whatever. And so, yeah, if you want to, there's a lady, Teepa Snow. She's Canadian. She does a lot to kind of help families also understand. So, Uncle Keith, the difference between dementia and Alzheimer's, I think that has been addressed. And then also ways of preventing the disease. The APOE4, that's the genetic predisposition to the condition, Dr. Palesa?
Yes, so the APOE4 it's a genetic correlate. So
Yes.
one can't necessarily test for it and say that one will develop dementia because it's positive, but it's a genetic correlate that we're starting to see. It's just that we don't routinely test for it. And then in terms of prevention, the most important thing would be to prevent the metabolic diseases that I mentioned earlier, the high blood pressure, diabetes, the raised cholesterol, raised BMI, because all of those things especially contribute to your vascular dementia or your mixed dementias. So trying to ensure that you're eating well, exercising, not smoking, and also keeping brain hygiene, so sleeping at appropriate times, and doing tasks that are stimulating to the brain. So not just merely just watching TV for long, prolonged amounts of time, but doing things that actually stimulate the brain has been shown to be helpful in preventing the disease. And then also just having meaningful interactions, because like I said, the association with depression and dementia.
Okay, thank you. And then a piece mentions, I've noticed that most health workers get dementia. My mom was a nurse for 44 years and most of her colleagues also died of dementia. I wonder why. I don't know if it's these sleeping patterns,
that would be a very
working
interesting
shifts.
study to look at, actually. I'm not sure if there have been any definitive studies.
Yeah.
But once again, that brain hygiene, because of our sleep patterns that are disrupted because of our careers, it may be that because of that, our brain hygiene is quite poor. But there is quite a lot of depression amongst healthcare workers, which may be that predisposition that is basically pushing us over. But I would, that is mere answering from supposition and not necessarily from concrete studies, but that would be my quick essentially.
Yeah, okay. Then someone says, not sure about the children. Mom says these people mustn't bring their children here. That's for great-grandchildren. So I guess everyone presents differently. My mom
that is true.
has been diagnosed, and she's angry with us at the moment because we had her institutionalized because she had psychotic episodes and she has to be medicated. So she wants to have nothing to do with my sister and I, because we put her in this place, and she's got no insight into her condition, and she's calm and she's okay, but she doesn't want to have anything to do with us. So we go see her, and then the childish behavior, like she doesn't want to look at you, she doesn't want to speak to you, can do for whatever you like, and then she just thinks, oh, whatever,
it's the unfortunate side.
You just have to do it.
Exactly. And keeping that interaction meaningful, even if she does sulk a bit.
And then bathing has now become a problem, and my young boys are behaving rudely. What do I do? Shame. Yeah, a lot of elderly people with dementia, not elderly, they don't want to bath.
So it's similar. Remember, like I said, you kind of go into a childlike state. So similarly to how you fuss and fight with children about them needing to bath, but also giving them the opportunity to putting it as part of a routine. So you wake up in the morning, you have breakfast, and now it's time to bath. You may have some resistance, but also giving the person some kind of choice or individuality to say, okay, are you going to bath now or are you going to bath later? So bathing is on the table, but are you going to do it now versus later? So finding ways to ensure that the person feels included in the decision, but also it does sometimes require, for lack of a better word, a firm hand to say that it is something that must happen, and finding ways to make the time around bathing, because what we found with my grandmother was that she didn't want to bath because she felt embarrassed by being bathed. So finding ways to make that less of a challenge for her. So leave her in the bathroom for a while, and then she'd call my aunt to come through to now help her. Because then at this point now she's no longer feeling exposed. So giving that idea of dignity and finding out why, because sometimes, remember, although they have this deterioration, they do sometimes still have reasons as to why they don't want to do. So finding out why don't you want to bath? And you may actually gain a bigger insight into it. And for my grandmother, was because she felt as though she was now being stripped of her dignity. So giving her some privacy basically got us now to a point where she was feeling comfortable being bathed again.
Okay. Someone here said shadowing causes me the most irritation. I now know better. I'll adjust my reaction. And is there a medication that can slow down the process?
Unfortunately not. Like I said, the things like the antipsychotics and the sedatives just help with some of the symptoms, but it's mainly just supportive treatments. In some places, they do give some treatments, some acetylcholine receptors, but it also does depend on the type of dementia. But for the most part, no. It's mainly just the supportive treatments and the nutritional aspect that's really important. But there's nothing that we can say can slow down the process definitively. Yeah.
Okay. And someone says she was given Risperdal for a mom, but can't see a difference. And a change in her behavior, had to report to a sedative as she's to resort, I think, to a sedative as she's very restless day and night. And I don't know, but my mom had to be medicated. She did Risperdal, Triptyline, and the initial doses were too low. They had to double everything because she experienced psychotic episodes despite being on the medication. So they had to kind of, up the dosage for her to get control. Otherwise, it's terrible. And I know it's very traumatic to see your family member behave in this way. Because with this, your body looks fine, but your mind is gone.
Exactly. So it is very important to discuss with your healthcare provider to say that this specific dose isn't working. What we've realized a lot of the times is that families don't report to us. You'll hear another person in the family saying, but did you tell the doctor about the Risperdal? And in catching that conversation, then you know that there's something wrong with the Risperdal. So report it to your doctor to say that at this current dose, the Risperdal isn't doing anything. It may be a very low dose because we do start at very low doses. And you may find that if we increase the dose, it works. Or you may find that for her, actually, the Risperdal may cause more agitation and she would respond better to sedatives. So then we must then stop the Risperdal. My grandmother, for example, didn't actually do well on Risperdal. It caused her a lot of extrapyramidal side effects and it actually blunted her affect quite a bit. So we stopped the Risperdal and just kept her on low dose sedatives, and that helped. So it must be something that you discuss with your healthcare provider to say that this is what we're seeing every time we give her the Risperdal. And just keep a careful monitoring, because sometimes people will say that every time she has the Risperdal, she starts to scratch. And then you notice that it's actually not the Risperdal, it's because she has the Risperdal after bathing. So you must keep a careful note of when it happens so that we can say that it is in actual fact the drug itself and try to do something about the drug.
Okay. Yeah. So, it's trial and error, I guess. What works for one won't work for another person.
Exactly.
Someone also says, you mentioned seizures later on. Are these petit mal seizures? So just explain what it is, the seizure they're talking about, please.
Okay.
Dr.
Okay. So the seizure may be, so petit mal seizures are focal seizures, and you may have focal seizures with impaired awareness, or you may have focal seizures with retained awareness. So this means one part, so for example, the upper limb, the right upper limb is shaking, and it's shaking by itself, basically just that right upper limb shaking, and the person is fully aware. So that's what we'd call a focal seizure with retained awareness. But you may have a focal seizure with impaired awareness, and then you can also have a focal seizure with secondary generalization. So it starts with the right upper limb, then it goes onto the rest of the body. So it can be a focal seizure, it can be a generalized tonic-clonic seizure, which is the one that we normally think of when we think of epilepsy. So it can be either or. It's just that they do, now remember, it also does depend on what kind of Alzheimer's it is. For example, with a vascular dementia, or not Alzheimer's, but a dementia. So with a vascular dementia, you may find that the person would have an actual vascular event that can be now associated with the seizure and then have focal seizures because of that. Or you may find that they may have generalized tonic-clonic seizures in another kind of dementia. So it really does differ from the dementias, and it does differ from the person. But any kind of seizure should be reported and then should also be treated, because the seizures in and of themselves, remember, also impair the brain's oxygenation, which would worsen your outcome. So we must make sure that the person isn't having seizures for prolonged periods of time, and they have to be started on anti-epileptic drugs.
And also, when you're old, they can aspirate, and as it is, pneumonia is a problem. Exactly. So, yeah. Then someone here, Astrid, she says, is this illness hereditary? Because we find ourselves doing funny things too. Is there counseling available from the conference for caregivers? I think support.
So I guess that's two questions. Yes. Sorry, you can just go first.
No, you go ahead, Dr. Palesa.
Oh, I was saying, it seems like there's two questions there. It seems like it's the one of inheritance, and then the other one is also of counseling and support. In terms of its hereditary, like I said, there's no specific gene that we can look at and say that this specific gene is causative, and if you have it, it is inherited in this autosomal dominant, etc. But the other thing that we must remember that we inherit from our family members and our parents is their eating habits. So with vascular dementias especially, we find that people continually do the same things as their parents, and then they have high blood pressure, diabetes, and develop vascular dementia. So it's not necessarily inherited in the sense of a gene proper that we can kind of point to, but there is an association. Then in terms of the counseling, I'm not sure if the conference has specific things, but there are some support groups that are available, some internet groups that are also available where caregivers can actually just speak to each other and share ideas about how to deal with this kind of situation.
And I think maybe the people that are on the platform, you can contact me if you want us to start a support group, because I think it is important and it is hectic to see your family members deteriorate in the way that they do, because as you mentioned, what actually happens is that their brains die before their bodies do. And this is what this lady also says that I told you about just now, Tipa. And she says the sad thing is that your brain is no longer working, but your body is okay. And that is very hard, especially if people are relatively young, for the spouse, because the relationship deteriorates. It's not there. You can't have any expectations because you will be disappointed all the time, and not of the person's doing. It's just the nature of the disease.
That is true.
So
that is true.
So Dr. Palesa, thank you so much. That was so informative, and you've covered all the aspects that I think people needed to know, wanted to know about. And let us start the support group. But the person also says not very easy when you're almost the sole caregiver with no support whatsoever. And this is where church people can come in. And I know it is embarrassing. I can say from my perspective, because my mother can swear and perform and carry on the way she does, I'm embarrassed to get the pastors to go to her, because this was a church woman and she's lost her dignity, and they won't recognize the person that she's become. And so you are quite reticent to let people go to her because you don't know what to expect. But if it's someone that is mature enough and they understand the condition, then I'm sure one can get support from people in the church. And maybe this is what we can discuss in the support group, so that you know, people who don't have support, you don't feel that you walk in the journey alone, and you also feel understood, because it's very difficult to explain to people who are not in the situation what it is all about. So yeah. Okay, thank you very much everyone for joining. It has been a wonderful session. I've learned a lot, and I'm sure you have too. And I'd like to thank Dr. Palesa for her time and her expertise to make things so simple. And Dr. Palesa, are you on the group again? It's fine. I'll just pray. Dear Lord, thank you so much that we could take time aside from our hectic schedules to just sit and speak about something that impacts our lives, that affects so many of us. Lord, we can't wait for your soon return when all of this will come to an end. It's very hard to live with someone whose mental faculties are not okay. And I just pray, Father, that you will give us strength and wisdom and help, that we can start a support group so we can support one another, and we do not have to walk this journey alone, because it makes it so much better when we feel that we are not in this on our own. Help us to also get wisdom from above, dear Father, so that we carry on with our lives, our responsibilities. And I just pray that you will lead and guide and give wisdom, and bless each one on the platform. Give us a wonderful evening. And thank you for your greatness and your goodness towards us. This is my prayer in your loving name. Amen.